My name is Linda Gail Becker from the Desmond Tutu HIV Centre, and I'll be bringing you up to date on pre-exposure prophylaxis. Indeed, our toolbox for prevention has become much more complete of late, but today I'll be focusing on one aspect, pre-exposure prophylaxis. This is because this particular type of prevention is universal, discreet, it is sex act independent, easy, safe, tolerable, and as I will show you in the next 20 minutes, highly effective. The story starts all the way back in 2010 at the Vienna conference, where we heard about Caprisa 004. This is a TDF gel study looking at the availability of TDF microbicide gel inserted into the vagina daily to prevent HIV acquisition by women who have sex with men. Subsequently, there have been 3 important pre-exposure prophylaxis trials conducted in men who have sex with men in the global IPREC study, women and men in the TDF2 Botswana study, and discordant couples in the Partners PrEP study, which showed really reasonable effectiveness in people taking daily TDF FTC or tenofovir emtricitabine, known as Truvada, to prevent HIV acquisition. Subsequently, we've seen over 5 years the progression towards a time today when oral PrEP taken daily is seen as a standard of prevention in many parts of the world. In fact, it has now been recommended by the WHO that oral PrEP containing TDF should be offered as an additional prevention choice for people at substantial risk of HIV as part of a combination HIV prevention approach. This is based on the results from 12 randomized trials where overall we saw a risk reduction of 0.5. However, it's been shown that where adherence is better, where the pill is indeed taken daily, at least more than 5 days out of 7, we see that risk reduction actually improving. And most recently, 2 clinical trials, one known as PROUD and the other IPEGAY, in men who have sex with men, have really shown very effective reductions in HIV. Not so for women, however, and this rather set PrEP back on the African continent, where of course the greatest burden is amongst women. 2 trials, one known as VOICE, the other is FemPrep, did not show effectiveness. And this led to a great deal of hypotheses that perhaps PrEP won't work in women. It may not be effective where the vaginal mucosa is the area of concern, or perhaps the fact that women may not want PrEP in Africa. Subsequently, meta-analyses have been done to show this is in fact not the case. In 5 different studies, although there was a wide variation of adherence and therefore efficacy between studies, it was shown that oral PrEP was effective with moderate to high adherence, showing a 32% efficacy with 50% adherence, but going up to 61% efficacy when adherence was much higher. Of course, it's important to know whether PrEP can be used by all female populations, and importantly now we do have WHO guidelines that support PrEP usage in pregnant women. It is thought to be safe and efficacious in women who are at risk of HIV acquisition during pregnancy. And we know again on the African continent, this is a very real concern. TDF-based PrEP is not found in breast milk and therefore is safe for lactating women. This study recently published in Nature Medicine shows that we still have some work to do in terms of making sure that our PrEP rollout is occurring in those countries when new infections are occurring in Africa. Moving to the next development in terms of oral PrEP, this is on-demand PrEP, and this is work done by the French group, both in France and in French Canada, showing that when a schedule of 2 pills up to 24 hours before sex, 1 pill 24 hours later, and then a second pill 24 hours after that, or the 2-1-1 on-demand regimen, can be shown to be as effective as daily PrEP. And this is only so far been shown to be useful in men who have sex with men and transgender women. And so the WHO has come out now with guidance in this regard. But again, just to remind everyone that for women who are exposed via the vaginal mucosa, it is still recommended to prescribe PrEP daily. When men are given the choice of on-demand or daily PrEP, it looks like there's a 50-50 stratification of choice in this regard. The next development is to use antiretrovirals other than TDF. And of course, this raises the question of TAF. So tenofovir alafenamide is a close cousin of tenofovir disoproxil fumarate, or TDF, and has been shown to be as effective as TDF for treatment, with some advantages in that it has lower plasma levels in lower amount, and therefore probably lower toxicity and potentially lower cost. And because it's been shown to be as effective in treatment, the question was, could it be used in prevention? And so this trial is now complete, known as Discover, looking at the efficacy and safety of FTC TAF versus FTC TDF as oral PrEP in cis, MSM, and transgender women. So this was a non-inferiority study conducted in Europe and North America. And the results of this are that, in fact, the F-TAF has been shown to be non-inferior to F-TDF. And here you see the results. 15 infections in the F-TDF arm and only 7 infections in the F-TAF. As mentioned, the pharmacokinetics are more favorable for F-TAF. The F-TAF achieves an EC90 more rapidly and has a longer duration on board, resulting in better PK. So the result of this is that the FDA has approved F-TAF for prevention in cisgender women. This was not, except for cisgender women. It has been approved for men who have sex with men and transgender women, but the study did not contain women, and the FDA has decided not to include. So there will be a study run in women next year in Africa to show that this alternative can be used in women who have sex with men. So thinking through, when would you use FTC TAF versus FTC TDF? And the kinds of things you might consider is, of course, if this is a cisgender woman, this is not approved at the moment. If there are concerns about bone and renal safety, then you might consider the TAF option. But there is the downside of potentially weight gain, and of course, at this moment, probably greater cost. Moving to PrEP version 2.0, we really do want to go beyond the tenofovir-based options and beyond short-acting or daily or on-demand type regimens to less frequent dosing. And for this, we're thinking about the long-acting injectables, the infusibles, the long-acting topicals, and of course down the road the implantables. So let's move first to the long-acting topicals, and this includes the dapivirine ring. So 2 trials run in Africa, one known as the Aspire trial, the other one known as the Ring study, showed roughly a 30% reduction in HIV acquisition in women who used the monthly dapivirine ring. This is placed vaginally, either by a health practitioner or by the individual themselves, and is left in situ for at least a month, and then it is replaced. In open label studies, which is a pattern we've seen with all the randomized controlled trials, that when women knew that they had the active ingredient on board, there was better use of the ring with an improvement in risk reduction. Here you see 0.5. So this went to the European Medicines Agency and has been approved now under a Section 58, so that WHO has also now incorporated this within their guidelines, and it will be offered to women in low and middle income countries as a second line to pre-exposure prophylaxis. Let's move to the long-acting injectables. And 2020 has been auspicious for new information about cabotegravir long-acting. Cabotegravir long-acting is a long-acting suspension for delivery via an intramuscular injection. This is a standard transfer integrase inhibitor. Its half-life is long in the oral form, and in the injectable is also long. And in this form can be offered once every 2 months. So a recent study looking at a double dummy, double randomization approach, where everybody received either oral TDF-FTC or a placebo, versus a injectable cabotegravir long-acting or a dummy injectable. So this was a complex design to show non-inferiority of the long-acting cabotegravir compared to oral Truvada. And again, a very pleasing outcome. This study 083 in men who have sex with men, first off, showing that indeed non-inferiority of the long-acting injectable was reached, and subsequent analysis showing that actually superiority was reached. So here you see 39 infections in the FTDF arm, and just 13 infections in the long-acting cabotegravir. Again, that pattern showing where oral Truvada falls down is with adherence. So as time progressed, people who were able to do more than 4 to 7 doses a week decreasing over time, leading to that superior outcome in cabotegravir long-acting. We know that particular populations struggle more than others to adopt a daily regimen, and so it really is important to have these other options, such as longer-acting injectable options. A study was run concurrently in women here in Africa. This is known as the LIFE study, or HPTN 084, similar design where everybody received a daily Truvada or placebo versus a daily long-acting injectable or placebo, and in this case looking for superiority in the long-acting cabotegravir. And certainly this has been shown to be the case. 34 infections in the study of more than 3,000 women in the FTDF arm, but only 4 infections in the CAB-LA, so a 9-fold reduction in HIV acquisition. Overall, a reduction in incidence across the whole study, meaning that we did see some benefit of the oral FTDF, even in this female population. Just alerting everyone to another long-acting injectable agent on its way. It will be going into trial next year in 2021. It's lenacapavir from Gilead. This is a first-in-class selective capsid protein inhibitor. Again, long-acting formulation, very efficient, and probably only requiring an injection every 6 months. So extraordinary PK profile there, and again, opening all kinds of possibilities. This is another very exciting molecule known as Latrovia. It's a nucleoside reverse transcriptase translocation inhibitor, so again, a new mode of action. Been shown to be effective both for treatment and prevention in animals. It is being developed both for treatment and prevention in humans. And here you see its first iteration as a monthly pill, very small, small dose, monthly pill. And the phase 2 is now complete in Africa. And we will be seeing this data, or at least the initial data and the PK data at R4P. And this is now moving into a phase 3 known as Empower 22, which will be starting in Q1 in 2021 in a number of study sites in Africa. There is also a study planned in MSM and transgender women. So again, the first iteration, a monthly pill, but also designed to be delivered in an implant. So this will be based on the contraceptive implant. It'll be reversible with removal, and really perhaps require even more than a monthly, an annual replacement. So we've seen the first data, the dose has been selected, and the implant based on Nexplanon contraceptive implant is now being developed for use in time to come. The infusibles, very exciting. This is using monoclonal antibodies with broadly neutralizing effect as again, a pre-exposure prophylactic in women who have sex with men and men who have sex with men. So the first studies are out. And those studies were known as the antibody-mediated prevention studies, as said, conducted both in MSM and transgender women, as well as women in sub-Saharan Africa. And these data will also be presented at R4P. Very exciting that we are moving into PrEP for the future, where formulations are going to be varied, the ingredients will be varied, and these will be designed for intimacy and lifestyle, not just for prevention. In that regard, we are also looking at multipurpose prevention technologies, and whilst not yet immediately available, we're very excited that MPTs will include PrEP with other STI type treatment and or contraception. And we know that there are intravaginal rings, vaginal gels, vaginal films, fast-dissolving inserts, and other barrier methods that are in development at the moment. We know from contraception that when women are offered choice, their adherence is better, their retention is better, the effectiveness of contraception is much improved. And so we believe is the same with PrEP, that when we offer a variety of antivirals in a variety of dosing frequency and a variety of routes of administration, that then people are more likely to use. And so choice becomes the most critical thing here. And as you can see, we now have a real toolbox with a variety of different prevention options, but it is in the pre-exposure prophylactic realm that we really see discretion for the first time. People can use these modalities discreetly with not necessarily involving partners if not possible to do so. And so now we can really think about client-centered prevention, where we consider the population, the risk associated, and offer this in an accessible, layered, and integrated way. We can say, who is sitting in front of me? Who is needed to prescribe? Which kind of healthcare worker? And which platform can be used for distribution? It really does invoke the concept of differentiated service delivery, where we can think about a wraparound service that is fully integrated, client-centered, and based in a one-stop shop. So everything we've seen in terms of community-led prevention, where peers are actually supplying the PrEP, all the way through to more automated, almost anonymous PrEP delivery systems. And here you see everything from ATMs to express clinics, vendor machines, and mobile clinics. So with that, I will end. The PrEP of the future is exciting. TDF FTC as version 1.0 has set a high bar for preventive effectiveness, but we now know that we can use this both as daily and on demand. It probably is going to be game-changing as we move into the less frequent dosing, so these long-acting preparations. The future is ripe with possibilities in injectables, infusibles, implantables, topicals. We are going to see an increasingly complex environment to test new agents, but with that comes a great deal of excitement as we roll out more options. And of course, multipurpose technology on the horizon for cisgender women, more on-demand options, and with that, we are probably going to need better platforms, better diagnostics, almost certainly need to demedicalize PrEP, and need a more sophisticated understanding and better partnerships with the most affected communities. Bottom line is more options are always better. And with that, I thank you and wish you all well and hope that you have a wonderful R4P. Thank you.